So it means you're getting old when you get the keynote address, I guess. But I think it also has to do with surviving 25 years in Chicago. So I'm here just because of my wife, but otherwise I probably would have moved on. But this is going to be a lot of review because it has to do with what everybody's talked about today. It's just kind of an evolution of technique and an evolution of thought when it comes to developmental dysplasia of the hip. So these are my disclosures. There aren't very many. I just wanted to go over too how I got involved. So I was a kid in Cleveland doing a residency, and I really liked the trauma work, and I went off to Charlotte, North Carolina, and did a fellowship in trauma. And my mentor there, Steve Sims, said, if you really want to do pelvic and acetabular fractures right, you should go visit Joel. Joel Matt. I can't probably tell this story, but so I said, yeah, I'll go out for a few months. And they said, no, you got to go for a year. I said, okay, well, I was supposed to meet him at the OTA one year, and myself and his current partner at the time, Mark Riley, got a little out too late, and I missed the meeting the next day. But luckily, he still took me under his wing after all that, and I spent a whole year with Joel. And a good byproduct of that was an introduction to the PAO. And this is fluoroscopically guided. So I think that's an important point, too, as far as North American PAOs with the start in Europe. And then I came here to Loyola with a practice that was mainly focused on trauma surgery. I did a little bit of preservation or hip reconstructive work at that time. So just to go back, as I said, everything is going to be repetitive. This is what Joel told us about a bad reduction. So this is my first PAO in 1999. So you can see it's probably hinged, posterior lateral. It's got a little over coverage. It's not really retroverted though, and it just has insufficient anteversion. So maybe just a little bit of a struggle during my first case, and I can remember it pretty vividly, actually. And she did pretty well, but she did end up with a little impingement and ultimately got a hip scope about 10 years later. So my early practice, though, was mainly focused on true dysplastics. They were lateral center angle of under 20, S-type index greater than 10. I used the classic Smith-Peterson approach. Oh, my videos aren't working, so can you run that upper video? So this is from a video I made back in 2004 as part of some courses that we were involved with, but it's the one that that Brett Chris showed. Now, if you ever do a PAO through that incision, you'll love it. It's absolutely fantastic exposure. It really gives you a good feel of what you're doing during that time. You get a good tactile sense. You get a good sense of how things move. And now we're operating through this little peephole that sometimes it takes away some of those tactile sense that you have from it. And I think that unfortunately it doesn't heal very well, though. It usually heals a little bit wider, and the cosmesis of the incision isn't that great. And I think the lateral femoral nerve is pretty similar, but we used to release the rectus all the way off to get our access over to the medial side. And as Joel talked about, I mean, I did the 5 cuts too to start, with the cut from the inside of the pelvis to complete it. And these were probably less fluoroscopically guided than they are today. And I think the one thing about going smaller with the incision is that we become much more dependent on fluoroscopy. So by 2002, I did a traveling AO fellowship, and it was mainly focused on hip surgery. I had the pleasure of working with this crew over here from the pelvic surgery group. That was Letronell disciples with Joel and Jeff and Keith. And then I spent 6 weeks in Bern operating with Reinhold. So I really had a great visit with Reinhold too, because Jeff called over and he said, I have this kid coming, can you stick around for 6 weeks? So he actually was there for the whole 6 weeks. We did a ton of surgery, and it was a fantastic experience. And I mean, the exposure from the Smith-Peterson and doing a PAO without fluoroscopy and some of the things he did were quite amazing. But it was a great experience, and it really kind of set the course for the rest of my life. So in 2003, I was a participant at the AO Hip Symposium. And after that, I became a faculty member and an organizer. And really what this did for my life and my career is that it set me up with a group of friends and colleagues that really were critical of what we did and how we did it and how we learned over time. And I would really recommend to do this for yourself. And maybe this meeting is a start for you guys. And it was actually in 2006, the birthplace of Anchor, where they actually had a meeting for Anchor. So early on, we did labral repair and labral surgery, but it was done open. We came up with ways to do it. You can see this is a femoral distractor that would distract the joint. We could look inside the joint. We could do the labral repair directly open. And we'd address some of these RIM syndrome problems. It was a real kind of difficult way to do it. Impingement was noted following the PAO, and I found it even in my first patient, and it can be multifactorial, as people have talked about. And so that's when the open osteochondroplasty came from. And really with the extended Smith-Peterson too, or the Smith-Peterson approach, that osteoplasty was very simple early on. And it is now today too, because you know how to do it through that lateral window and you're confident on what you're going to do. But early on, I used to mark the deformity with K-wires so that I could do an adequate resection and make the head as round as possible. So I used a little bit of cheating with that, the fluoroscopy there too. And these are the results everybody's been over, but nobody really talked about too is that this last study was published in 2024. And it always brings into question, what we're doing all the time, but a propensity matched group of patients that had osteoplasty, osteochondroplasty, and those that didn't really showed no difference at long-term follow-up. So it does give you a pause a little bit, and maybe in some patients there may not even be a role for it, especially if they have higher anaversion or other morphologies that may protect the hip. So hip arthroscopy gained popularity in the 2000s. It gave absolutely a better intra-articular evaluation than ever what we saw. It's a more elegant method to address the labrum for sure. And it was an additional method to address offset abnormalities, especially in dysplastic hips. And there are multiple studies that showed the use of the arthroscopy in conjunction with PAO is very useful. And so you can't argue that. I think it's a technique that's superior to anything that you can do open. The question, though, is do we really need to do it? And this has been shown a number of times, and I was part of the group that recruited patients for the randomized control study. As Robbie said earlier, it was very interesting to have the discussion with these patients, and since the studies come out, it's actually very interesting to have the same conversation. Because the one thing, too, is in our environment here in Chicago, there's almost an expectation that you take a look at the labrum. They come to your office and they're like, "What? You're not going to do anything with my labrum?" I'm like, "Well, it's not really even detached much, and it looks pretty normal." "Well, I think I want to have that looked at." And so you say, "Well, we might look at it, but we may not do anything with it." Well, that's okay, but I just wanted to make sure it's okay. So in some cases, we end up doing that. And as Ryan said earlier, sometimes it's maybe 1/3 that we don't do anything at all with the labrum, or even more when we take a look inside. And then there's the approach modifications. They become smaller over time, transverse, better looking, rectus sparing. It may help mobilization of the patient, and it may improve the in-hospital rehabilitation, but I think it makes the surgery a bit more difficult, actually. And it's not, I don't want to say it's not that difficult, but I think the way we started was a much easier way to do it because you had a much greater exposure and much better control of everything. And these approach modifications really only became more realistic with the use of fluoroscopy. So I think we're very fluoroscopic dependent right now in what we do. And it may be okay, though, because if we have arthroscopic treatment or no need to address the central compartment, then maybe we don't need a larger incision. So it does give us the opportunity, though, that if you do a smaller incision, there's a case that we did. This lady's morbidly obese. She's got a hip at risk. And maybe it's a good idea to do this, maybe it's not, but she's got a severe dysplasia, she's got hip pain, she's got subluxation, she's not a perfect candidate, but she's also not a total hip candidate very easily. So with this different approaches with the transverse, you can address the femur first, get set up for your femoral osteotomy. You can expose the ischium, as I think John Clohissy brought up earlier. You can perform the ischial portion of the cut through the lateral approach to the femur. Move forward with your femoral osteotomy, a little bit of varus, a little derotation. Still looks good with the abduction view. And then use a more limited approach just along the abdominal region, a transverse dissection above the above the appendix crease, and you're out of the zone of the soft tissue problems, and they heal quite readily. I mean, it's not a perfect reduction or a perfect correction, but it's a pretty durable correction. She's now 4 years out. She healed without difficulty. She just had her hardware removed, and her other hip was done as well. So what is the role of PFO in conjunction with PAOs? It was covered earlier by Joel, and I think the femoral pathomorphologies can be corrected to help this out. I think the axial plane is a little bit easier with the severe dysplastics, but when do we correct the coronal or the axial plane or the rotational deformities? And I really don't profess to know the answer to that perfectly, but we'll go over a case. But in the Burn series, from the very beginning to their publication with Michael Lunig on the algorithm in the mid-2000s, they went down from 10% PFOs down to about 2%. I think I'm probably still a little bit higher than that in my series. But I'm with Keith Mayo. I never really regretted doing a PFO, but I've regretted not doing one. So there's some situations where you just wish you would have done it early on. There's papers that can help us predict that, and I do agree that probably doing the acetabular side first is a little bit helpful to know whether or not you need to address the femoral side, but then that allows you to get the socket into position. You can do some functional views and see whether or not the PFO will be helpful. And if you're going to internally rotate and flex, that might give you a little more information on what the derotational osteotomy might do for you. So here's a patient. She has left greater than right groin pain. She's got a true dysplasia. She has femoral version of about 30 degrees. She underwent a PAO on the left. I think it's an okay correction. It's not perfect. Probably it could be a little bit flatter and maybe a little more lateral coverage. She remains symptomatic post-op, mainly groin pain. No irritability of the hip, though. She had mainly some psoas-related symptoms. Went through a ton of rehab, tried psoas injections, tried everything else, and I said, I think your hip's still just a little bit unstable. We did some fluoroscopic views. It couldn't demonstrate it at all, but she was tired of the hip and she wanted to go through with the proximal femoral osteotomy. So we did the proximal femoral osteotomy and she did really well. She came back and did the other side. We did the same thing right off the bat. Now she's 5 years out. She's getting married next month and she's happy with her hip. So it's anecdotal, of course, but I don't know exactly when is the best time to do it, but I'm like Brett. I probably start my conversations around 30 degrees of anteversion, especially if they have uncompensated version. I'll start to have the conversation as to whether or not to do the femoral side. And I think this is a big thing that we haven't really talked about today. And Mike Willey took on the project with the Anchor Group to look at perioperative protocols. He looked at 16 of surgeons. We went over a bunch of different things. And really what they've shown is that whatever we're doing with regards to no longer doing neuraxial blocks, doing general with local infusion or local periarticular injections, multimodal pain regimens, pre-surgical PT in the patients that you think might be at risk for not being able to get up and move around, or use of CPM, we've really decreased the length of stay, which has been brought up a couple of times today. And 6 of the 16 surgeons, when this study was done, had already started to implement same-day discharge for PAOs, which I don't know if it's realistic for us right now, but it's still a goal for us as well, is to get to that point. But I think it also takes a lot of patient education to help get there. There's been no shown benefit to rapidly progressive weight bearing. I got a little nervous when I saw John's PAOs within 4 weeks, so you start to weight bear on your limb a little bit early. That's been shown to have an increased risk of ischial stress fractures at the ischial ramus. So I have not progressed with my weight bearing as quickly as John showed. But really the most impactful thing in my practice over the last decade has been the short, we used to call early on the short horizontal roof. So it didn't look like a true dysplasia to us, but it was definitely undercovered. Is the head too big or is the socket too small? What is it? And before 2013, I referred everybody with an LCE greater than 20 out to other people to take care of with arthroscopy. That probably wasn't the smartest thing for me to do either. And instead of trying to think about the problem, I tried to get rid of it. And really, I didn't do any PAOs on patients in this group until probably 2013 when I was downtown here at Northwestern now. But since that time, and I think since scopes have been more common in the borderline hip, failed scopes became a really big part of my practice. They started to show up in my clinics, multiple surgeries, multiple scopes. And I think it brought that to light for me is that maybe we just need to better understanding and understand how to treat these and get a little further along on that at that point in time. So over the years, there's been a lot more things that have been brought up to help us better understand that word instability, Joel, I guess, or whatever we want to call it, of the hip, making sure we're getting functional radiographs. What does it look like when a patient stands up? The classifications are different, looking at different indices or what the contributions are to the hip so that it's loaded differently and it's still painful for the patient. I think that always in the back of my head was a study that came out, I think this was 2017, about how failed hip arthroscopy negatively impacts the early patient-reported outcomes in PAOs. And so for me, that was always like, well, maybe we should always think about doing PAOs first. So we'll go through a couple of cases just over the last few years. So this is a 14-year-old. She's hypermobile, in-towing, had right hip pain. She underwent a series of 2 surgeries on her right hip. She had arthroscopy for a labral repair along with a proximal femoral osteotomy for derotation, and then a subsequent hip arthroscopy with labral repair or labral reconstruction. Continued to have right hip pain. And so you can see now she has iatrogenic dysplasia. That's a little bit of a shorter roof. And now she also has some subluxation on her false profile. You can see the head trying to come forward. And so that's a difficult problem. She's now 18 months out. We did a right PAO. It's still a very small socket. She's improved, but not great. She still has quite a bit of pain, especially with any kind of activity. But she did go on to heal, and I don't know how durable this hip is going to be. But I think what we learned is that when we start to look at that data, on who had a hip or a scope, then a PAO, maybe we have to look at, what those PAOs or what those scopes had done initially. Like in this lady, there's her final follow-up films. And there. But in this lady, she had bilateral hip pain at the age of 17. She was a very active athlete and underwent hip arthroscopy with just a very minimal rim trim and a labral repair. But she came in with persistent pain. You can see she has acetabular retroversion, a relatively low volume socket. And she also has, on her CT scan, about 5 to 7 degrees of femoral anteversion. So she is an impingement patient. She's got a low volume socket. And after prolonged discussion, we decided that a PAO was best for her, and in order to make certain that we had improved motion following that we also talked about the possibility of doing a proximal femoral osteotomy at the same time. So we actually staged these 4 months apart, and she had proximal femoral osteotomies and her PAOs, and she's now over a year and a half to 2 years out. Her hardware's removed, and she's a nurse on our orthopedic floor at Northwestern, so she's doing better. But this is my patient now. She's a 17-year-old swimmer. She had left hip pain that began after squatting, doing frog kicks. She's a very active athlete. She plays softball as well. On her left hip, you can see she does have a lower volume acetabulum. She's got a high anteversion femur, about 30 degrees. She has no alpha angle or no offset abnormalities. And she has a low anterior centerage angle too. So my worry with her was that I was not afraid, but I was concerned about if I covered this, if I left a little bit too much anteversion with her acetabulum, that she'd still have some instability with her high anteversion femur, which is non-compensated. I'm sorry, compensated. And so here's her post-operative X-ray. She never got better after surgery. She always had some pain. She always had growing pain. You can see I probably had an okay lateral correction, but maybe a little bit too much anterior wall index. And you can see that the anterior coverage on the false profile is probably a little bit excessive. Even though we did a subspine decompression, she continued to have impingement. So she went on to hip arthroscopy, and she had the labral repair done. She did not have any arthroscopy with her first case. That was her labrum at the time of the reoperation, and she had a large subspine decompression, and she's just a few months out now, so we don't know the end of the story on that one. But I think it shows you that, you know, you can sit on either side of the fence and you can say, well, with borderlines, we should do this or we should do that. I think there's probably not a perfect answer for each one. And I think, you know, what we're looking forward to is what Jeff is doing with the Anchor Group. I mean, they have over 1,000 patients now enrolled with hip scopes and with PAOs, and we're really looking forward to what the data is going to show with that group of patients. So, and this again, coming full circle, is about, you know, the relationships that you have and who you hang out with and how you look at all your data over your life. So in conclusion, the PAO in the future, I think the perfect correction is going to have to be individualized, but I think there will be a role for 3D planning and navigation in the future, like where we put the socket and what we can understand from preoperative evaluations and whether or not that will show up at the time of surgery. In borderline hips, we need to understand when is the scope alone sufficient, you know, and with the PAOs with the borderline hips, I see a lot of these patients that are overcorrected. They have a downsloping sourceal. And is that going to have long-term implications with their outcomes? It did at the 20-year follow-up with the burn group. Or is there a role for some of these patients for PFOs only? I watched Reinhold Gantz do a surgical dislocation and a femoral neck osteotomy for a low-volume socket with coccyvalga when I was over there in 2002, but that never really caught fire. So. And now we're still asking the question, when do we do the femoral work or the labral repair? I think that will start to show us a little bit more over time. And I think the one thing too is to really talk with your patients or get a group of people in your practice to talk to patients and to decrease the impact that the surgery has on them. I think if we educate well, they understand what the process is, that we can start to make it less of an impactful surgery for the patients. And I think we're starting to do that. So it's not as scary of a thing that patients come into. You know, there's Facebook groups and other things, and if they have a good experience, they get out of there in a day. Their pain is well controlled. I tell my younger patients, they're bored by 3 weeks. They're ready to get going. They're starting to heal. The older ones we worry a little bit more about, though. So thank you very much for sitting and listening to me and hanging out. Have a safe trip home.